Hello, everyone, and welcome to today's special event with Meena Seshamani, the Deputy Administrator and the Director of the Center for Medicare, run by the Centers for Medicare and Medicaid Services. I'm Mark Duggan, the Trioni Director of the Stanford Institute for Economic Policy Research, and I'm really happy that you're able to join us this afternoon for what I think will be a really interesting conversation. I hope that you all had a really nice Thanksgiving and that you're gearing up for more holidays in the weeks ahead with your friends and family. I'm already looking forward to a very exciting lineup of events here at CEPR for 2023, including our annual Economic Summit that will be held in person on March 3rd, 2023. We have many other events happening earlier in 2023 too, so please stay tuned for those invitations and announcements about our speakers who will share interesting insights from the front lines of business, government policy, and academia too. Today, I'm really thrilled that Meena Seshamani is with us to discuss the Medicare program. Medicare is a program that has been the subject of a lot of my own research, so for me, it's an extra treat to talk with her today. According to the most recent estimates from the Federal Centers for Medicare and Medicaid Services, most recent estimates from them, Medicare spending will total $992 billion this year, just shy of $1 trillion, and is insuring about 64 million Americans, or 1 in 5 Americans. Most people who are on Medicare are older than 65, but about 9 or 10 million are also eligible through the Social Security Disability Insurance Program before reaching age 65. Medicare accounts for about 15% of total spending by the federal government, and it's about 20% of our healthcare sector. It's a big, 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 important program, and it's one that I think is, I'm really excited to talk about. So today, Meena will be discussing CMS's vision for the Medicare program to advance health equity, to expand access to affordable coverage and care, to drive high quality person-centered care, and to promote affordability and sustainability. Those are some very laudable goals. I look forward to hearing more about them. This all fits very neatly into CEPR's strike zone of focusing our research on issues that can have a real public policy impact. Many of us at CEPR study healthcare in general and the Medicare program in particular. Having this connection with Meena demonstrates our commitment to building a strong bridge between academia, I apologize for the phone that's ringing here, and the front lines of the policy world. This sector is of particular interest at CEPR since healthcare is actually the largest sector of the US economy, accounting for about 20% of GDP. I first met Meena when we both worked in the Obama administration more than a decade ago in 2009 and 2010. At that time, I was working at the Council of Economic Advisors, and Meena was serving at the US Department of Health and Human Services. She was a hugely influential and positive presence in our collective effort to design, to pass, and to implement the Affordable Care Act. And all of us on the economic team were continually impressed by Meena and our other colleagues at HHS. Meena has a very diverse background as a healthcare executive, health economist, physician, and health policy expert. And that really gives her a unique perspective on how health policy impacts the lives of patients and of healthcare providers. She has served as Vice President of Clinical Care Transformation at MedStar Health, where she conceptualized, designed, and implemented population health and value-based care initiatives. She also cared for patients as an assistant professor of, I never get this, pronounce this right, otolaryngology, head and neck surgery at the Georgetown University School of Medicine. I think I did okay, but not great. You would think I would have that down by now as a health economist for 25 years. But so Meena served on the leadership team of the Biden-Harris Transition HHS Agency Review Team, and she was the director of the Office of Health Reform at the US Department of Health and Human Services, where she worked on the Affordable Care Act, which is when we first got to know each other. Meena has many impressive credentials. She received her bachelor's degree with honors in business economics from Brown University, her MD from the University of Pennsylvania School of Medicine, and her PhD in health economics from the University of Oxford, where she was a Marshall Scholar. She completed her residency training at Johns Hopkins University School of Medicine, and she practiced as a head and neck surgeon at Kaiser Permanente here in nearby San Francisco. If that is not accomplishment enough, I understand that Meena also holds a second-degree black belt in, I believe, jujitsu. Some form of martial arts. She'll tell us in a second. So she is definitely a force to be reckoned with. With that, please join me in welcoming Meena Seshamani to CPER to discuss the Medicare program. After her presentation, I will ask her a few questions, and I invite you to submit questions anytime throughout the event as well. There should be a link on your screens for doing this. So thank you again for tuning in with us today, and thank you so much, Meena, for being with us. And you can correct me on my martial arts or any other fact that I just tried to provide. Welcome, Meena.
Thank you, Mark, for having me. It's great to be here with all of you. So my second degree black belt is in Subak Do, which is the forerunner to Taekwondo, so Korean martial arts. So close.
That sounds even more scary, impressive. So in any case, good. I'll be extra nice. I didn't know this about you back in 2009 and 2010, Meena. I might have been even nicer to you than I had. Anyway, okay, sorry.
Well, it's great to be here with all of you, and I look forward to the discussion. I think great, thank you. So I'll just walk through, as Mark mentioned, the vision for Medicare and some of the work that we are doing. Mark mentioned the important link between academics and policy work and operations. That is something that is very near and dear to my heart as someone who has worked in the academic environment and then carried that over both to operations, leading service lines like community health and case management and geriatrics and palliative care, to the policy realm where I am now. Because ultimately, I think at the end of the day, the only way that we're really going to drive change in our healthcare system is by everybody working together. And there are many perspectives and experiences that need to be brought to bear, and opportunities for engagement and for driving that impact if we want to have that collective change in the system. So if you go to the next slide. So I will go through some basics of the Medicare program, but probably don't need to spend too much time on that, and then focus on the vision for Medicare. I published a piece with my colleagues in Health Affairs in January, really mapping out where are the areas that we want to make sure that we're driving change. And to Mark's point, noting that Medicare is the largest payer in our healthcare system. And so where you make a change in the Medicare program, it oftentimes has ripple effects throughout the entire ecosystem. If you go to the next slide. So starting off in terms of Medicare, this may be review for some of you. There are several parts to the Medicare program. Part A is hospital insurance and institutions. Part B is medical insurance or kind of clinician care. Those parts together comprise traditional Medicare or fee-for-service Medicare. Then we also have Part C, Medicare Advantage, where Medicare partners with private plans to provide Medicare coverage for people with Medicare, oftentimes also including drug coverage there. And Part D is the prescription drug coverage program for people to have coverage of their prescription drugs. The next slide. So some basics on the current state of the Medicare program. More than 63 million people are in the program. Medicare Advantage is a key piece of this, with more than 45% of people enrolled in MA. There are higher proportions of minorities and dually eligible populations in the MA program as well. As the nation's largest payer, we partner with more than 1 million physicians, 6,000 hospitals, 15,000 skilled nursing facilities to provide care across the country. And diving in a little bit more, and we'll get into this further in the presentation, accountable care organizations is a key avenue by which our partnership with the healthcare providers really takes hold, where we want to drive a more holistic approach to care, to look at cost, to look at quality. And our Medicare Shared Savings Program is the largest accountable care organization program that has significant savings year on year, most recently in 1 year, $1 billion in savings, and every year achieving higher quality metrics than with those providers not in the program. And lastly, as Mark mentioned, we are the nation's largest healthcare payer, about 4% of gross domestic product. I remember I was doing a panel with Mark McClellan at some point, and he commented that in one regulation that we put out, he said, Meena can move more money than the GDP of several countries. So, it definitely is a very large program where, again, the work that we do really has tremendous impact and presents tremendous opportunity across the system. Go to the next slide. So we'll dive now into, our vision. So CMS as a whole, the vision is to serve the public as a trusted partner and steward to advance health equity, expand coverage, and improve health outcomes. And there are, 6 pillars associated with this that I will walk through and kind of speak to what we have been doing thus far with the Medicare program and, kind of open conversation to the work that lies ahead. If you go to the next slide. So the first pillar is on advancing health equity. And I think all of you know why this is so important. The pandemic certainly brought to the forefront issues of structural inequities in our system, the disparities that exist that lead to health inequities. And what we want to do is advance health equity. And what is health equity? It's enabling everyone having fair and just opportunities to achieve their optimal health, regardless of race, ethnicity, gender identification, sexual orientation, geography, language, culture. We all know that there are a myriad of factors that impact someone's health and their ability to access healthcare. And we strive for everyone to have that fair and just opportunity to achieve their optimal health. And in order to do that, we really need to look at people as we are seeking to care for them in our system. So in the Medicare program, there are kind of 2 big buckets within which we are looking at health equity. The first is our everyday operations. When the system is difficult to navigate, it's not the MD, PhD that necessarily has problems, right? It's people who maybe don't have family support, don't speak English fluently, don't have, advanced degrees in healthcare. And so where we can really make sure that the program is as navigable as possible and as comprehensive and, seamless as possible, that is going to support those who otherwise might fall through the cracks, particularly those with multiple chronic conditions or with complex social needs. And so to this end, we are looking to improve data collection because it's hard to improve what you don't measure. So we are, for example, going to be collecting race and ethnicity data in enrollment in Medicare Advantage and Part D. We have done requests for information on how we can stratify quality metrics across our various quality reporting programs so that you're not just looking at the average quality, but you're able to see what the quality is across different populations so that you can really drive change. We also are looking at other operational metrics, for example, for hospitals to have governance systems in place to make sure that they are addressing health equity as part of the running of their operations as well. The second aspect of health equity are more specific policies that we are using to focus on, for example, efforts to address social needs. So for example, we are requiring that Medicare special needs plans screen for health-related social needs for all of their enrollees, because certainly they tend to have more vulnerable populations that they care for. As I mentioned on the data side, we're looking into how we can stratify quality metrics, and we want to see how we can then reward reductions in disparities through our various payment programs. We also have a lot of work around rural health and behavioral health, as these are 2 really focal areas for driving improvements in equity. So with behavioral health, we are looking to mobilize our behavioral health workforce. We just finalized various payment policies to enable licensed marriage and family therapists, licensed professional clinical counselors, and others to be able to provide care to Medicare beneficiaries under a more general supervision by other clinicians, especially in rural areas and underserved areas, that really opens the door for improved access to behavioral health providers. We're also looking about how we can make that care more effective. paying for psychologists and social workers, for example, to provide behavioral health as part of a primary care office visit. So you're encouraging that more team-based approach to care. And we're looking to address our substance use disorder crisis in our country. So for example, paying for mobile vans to deliver opioid treatment programs where people are, meeting people where they're at. And I mentioned rural health. We're doing a lot around rural health, from our telehealth provisions, expanding telehealth, making it permanent for after the pandemic for behavioral health, and also implementing the rural emergency hospital provision, whereby hospitals can keep their doors open in rural areas by creating this new provider type and really taking an approach of supporting financially these hospitals that we maintain access to care. Next slide. So moving from equity to access. Obviously, access is foundational for us to be able to achieve health equity and for people to be able to get the care that they need. And so some things we're doing here, looking first at enrollment in Medicare. We put out a regulation to create new special enrollment periods for people to be able to come in and enroll in Medicare, including people with Medicaid who lose their Medicaid coverage. This is very important. Whenever the public health emergency ends, there are people on Medicaid right now who may no longer be eligible for Medicaid, but could be eligible for Medicare. And so we're creating the special enrollment period so that people can be able to enroll in Medicare. People who were incarcerated when they are no longer incarcerated, enabling them to come in through a special enrollment period. And importantly, in this regulation, we also expanded access for those who have a kidney transplant to maintain coverage for their immunosuppressive therapies for 3 years after the kidney transplant, to enable them to then find additional coverage, but to really create that bridge for them. We also have concerted efforts around our financial assistance. You know, Mark mentioned about other work that I had done before coming to lead this program, you know, taking care of patients on the ground and leading in a provider organization. I know all too well that you can have a great policy or program, and it really matters how that plays out in the last mile to reach people. And when I took this role, I learned that only half of eligible seniors for the Medicare Savings Program, which provides financial assistance, only half were actually enrolled. And so we have a concerted effort to increase enrollment in the Medicare Savings Programs. So last year's open enrollment period for Medicare, I was doing all these media tours talking about, you know, you should check if you are eligible. And in one open enrollment season, we increased enrollment by 800,000 people. So really trying to, again, take these policies to the last mile so that people actually have access to the good opportunities that are available. I mentioned behavioral health, as that plays an important role in both access and equity. And then moving to some, you know, lessons learned from the pandemic. You know, we've learned a lot, I think, about access for preventive vaccines, where in the Medicare program, we increased payment for in-home provision of vaccines. Because again, there are vulnerable populations that you wanted to be able to bring vaccines to where they are. And these are lessons learned that we'll take moving forward as we evaluate, not just for COVID vaccines, but others. How can we continue to improve access? And cancer screening is another good example. You know, dovetailing with the president's Cancer Moonshot initiative, we finalized in our recent regulations that the age is lowered now to 45 for being able to get a colonoscopy at no out-of-pocket cost. And also we are phasing out the out-of-pocket cost associated with a polyp removal when there's a screening colonoscopy. Those are just two examples. And if someone gets a FIT test or a Cologuard and they need to have a colonoscopy, that colonoscopy will also be covered without any out-of-pocket cost. Because again, we know that out-of-pocket costs can limit access, and we want to make sure people are able to access their preventive cancer screening. And the last aspect in this area is the Inflation Reduction Act. So as you may know, starting January 1st, insulin will be available, a month's supply of insulin for each covered insulin product at $35 a month, no more than $35 a month. And recommended vaccines will be at $0 out of pocket, and deductibles will not apply. So we are hard at work putting into place these provisions to, again, improve access to care by increasing the affordability, reducing out-of-pocket costs. Go to the next slide. So moving to our next pillar, really around innovation, whole person care. This is really our pillar around value-based care and alternative care models and payment models. Here is where there's a lot of work that we're doing in a partnership with the Innovation Center, where the Innovation Center is the R&D arm for the Medicare and Medicaid program, where they can test different ways of paying for care and providing care, and then where something works, we can scale in the Medicare program. So as I mentioned, we have the Medicare Shared Savings Program, which is the largest accountable care organization program, where groups of providers come together to be these accountable care organizations, where they have quality metrics to meet. And if they spend money in a smarter way, then they can share in the savings or potentially share in any loss. And as I mentioned, these models have been very successful. So we recently, in our regulations, finalized the largest changes to this program in the past 10 years to really encourage more participation by providers to get more people in this program, particularly in rural and underserved areas. So as one example of some work that we are doing, we're creating a new program, the Advanced Investment Payment Program, where we will provide upfront investment dollars to smaller providers in rural and underserved areas that they can invest in infrastructure, in their care teams, in the social needs of their patients to help them be successful in the accountable care organization program. This is building off of a very successful test that was done in the Innovation Center, where being able to improve care in rural and underserved areas is a pretty good bet for the program. It really increases quality metrics, and it ends up saving money overall because you are keeping people healthy and you're preventing hospitalizations, ER visits, et cetera. Another example of the collaborative work we're doing is through our national quality strategy, where we want to align quality measures across all of our programs. I know this from having led these programs on the provider side, where we had a huge spreadsheet with all of the various quality metrics that we were being held to by the different payers. It can create confusion. It can make it hard to drive change. And so we are working on how to align these measures so that you can really drive change in partnership with providers. If we go to the next slide. So the next area that we're focusing on is sustainability and stewardship. We want to make sure that the Medicare program is affordable, and we also want to make sure that it's sustainable so it is around for future generations. So an area that we're really focusing on here is competition, transparency, data, so that we can continue to be a responsible steward of the program. So some things that we're doing in this regard. So we do our payment updates every year for the various providers. A lot of this is specified in statute. So you have Medicare law, which dictates things. Then within that, you have flexibilities that we use through our regulations. And so where we have flexibilities, we look at how the payments are done, utilizing data and speaking with various experts and stakeholders. We are hard at work implementing the Inflation Reduction Act. I mentioned some of the aspects of the law that people with Medicare feel in terms of lowered out-of-pocket costs. There's also the side of the law around drug negotiations. So next September, we will announce the first 10 drugs that Medicare will negotiate. And the clock has started on inflation rebates, whereby if manufacturers of certain drugs increase the price faster than what would be expected with CPI-U inflation, then there is a rebate that is paid back to the Medicare program. I mentioned transparency and data. Some examples of this are the hospital price transparency program that we continue to iterate and update to provide charges available for researchers such as yourselves to be able to use. Also, we, for the first time, released PCOS data on ownership status, mergers, acquisitions, ownership status of various types of providers. Again, so we can put information out there that can be utilized to examine the impact of competition and to, further improvements in that regard. And lastly, I mentioned this already, making sure that our payment systems are up to date and accurate, and working on program integrity, waste, fraud, and abuse. So I think with all of that, a lot of work ahead, a lot of work that we're doing. And what's really important for us is engaging everybody in this journey with us. Medicare is a very large lever, as we've talked about, but it really is only successful in partnership with everyone else. I mentioned there is Medicare law that's at, the 50,000 foot level. There are the policy regulations we do at the 25,000 foot level. And then there's how care plays out on the ground, and our partnerships with academia, with providers, plans, patient groups, manufacturers, to be able to really drive improvements in the program, being able to hear ideas from all of you, being able to utilize the information that you have, and then being able to engage where there is a policy that we are considering or a program that we are putting into place to make sure that that comes to life on the ground to really achieve the impact that we all want in the healthcare system. I must mention COVID-19, of course, that, appreciate all of your efforts to continue to encourage people to get COVID-19 vaccines, follow public health guidelines. And lastly, I would be remiss if I did not mention Medicare open enrollment. We are in the midst of open enrollment right now until December 7th. And it's so important for people to be able to go and see if they have the best choice for them. As I mentioned at the start of this, there are various parts of the Medicare program, and different things work for different people. And so encouraging people to go to medicare.gov and go to the plan finder to be able to see different options for them, or calling us at 1-800-Medicare. It's available 24 hours a day, 7 days a week, to help people to figure out what plan might be best for them. And especially with the changes I mentioned with the Inflation Reduction Act, the $35 copay cap for a month's supply of a covered insulin product, the $0 out of pocket for vaccines. These are things that, can be hard for people to understand and navigate. And so encouraging people to call us so we can help support them as they're making their choices. So I think that's it. So I think with that, we will, Mark, I'll turn it back to you.
Well, great, Meena. Thank you so much for those remarks. And it is, really nice to see you and appreciate the slides as well that provided a lot of helpful background. And, we've got some good questions already coming in from the audience. Great. And I'll just start with some questions for you. And you feel free to just say, this is for me, it's a real treat because, as you know, Medicare is a passion of mine. It's the focus of a lot of my own research. And I want to, so there's so many things I would like to ask, but we've got, I can only so much time. So just for starters, I guess one big change in Medicare since you and I worked together back in, let's say, 2009 and 2010, perhaps from my perspective, I think the biggest change in Medicare since then is the spectacular increase in Medicare Advantage enrollment. And I'm just curious, from where you sit, what do you see as the drivers of that? And it obviously has much more penetration in some parts of the country than others. So I'm just curious what you think has been behind that.
Well, yes, there has been an increase in enrollment. I think it is most likely multifactorial. And this is one of those areas where I think research can really help, right? To identify why there are differences across regions of the country and what are things that are driving that increase. From my perspective, what is most important is making sure that all aspects of the Medicare program are rowing in the same direction towards that vision that we've been discussing here today. And to that end, we put out a request for information on Medicare Advantage to say, okay, how is Medicare Advantage performing in advancing health equity, in access to care, innovation for higher quality, more holistic care? stewardship and, sustainability, because we want to see where Medicare Advantage may be doing well that we want to further encourage, and where are there opportunities for improvements that we can address. And we have gotten a robust feedback through that request for information, really from a variety of stakeholders involved, including from academic. And that is something that we are looking at as we move forward and we think about policy in that area.
Terrific. Thanks so much for that. And then I may have some like little requests as we go through too, but and recognizing that you can only achieve, you're one person, it's a big federal government. So I may have little requests as we go through too. So it's interesting, you mentioned Mark McClellan. I first met Mark McClellan. So he's the former administrator, right, of CMS, former FDA director, Council of Economic Advisors, lots of important roles. And he's, for me,
alum of Stanford, right?
Yeah, used to be at Stanford. That's true. Absolutely. And for me, he was often sort of an inspiration, because he did, great academic research, and then he went into the policy arena and clearly had made huge contributions. In fact, I think he was a big part of designing Medicare Part D. And that was, that's a very important change to Medicare that preceded our work together a bunch of years ago. But it's interesting, when I was a graduate student, I was working on a program that you also know well called Medicaid. And Mark at that time, most of his research at that time had been on Medicare. And he talked to me, you mentioned dual eligibles. Dual eligibles, I think, are a very interesting group. About 1 in 5 Medicare recipients are dually eligible, low-income Medicare recipients, low-income, low-asset Medicare recipients are dually eligible, get sort of, quote, double coverage or dual coverage through the Medicaid program. And it is, it's a group that I guess I want to flag this group because, for those who are watching, I think that it is, it's a group that is obviously, we talked about equity. This is among the most disadvantaged people in our society, low income, elderly and or disabled. And they have not been the subject. So if you look, they're about 1 in 10 recipients of either Medicare or Medicaid, but they're about 1/3 of total spending, Medicare plus Medicaid. So they use a lot of care, reflecting the fact that they are in worse health. But if you look at sum up the entire voluminous literature on Medicare or Medicaid, that group has attracted almost no attention. So I'm just curious what you think are big issues for dual eligibles, because I have, a terrific PhD advisee now who's starting to work on it. I think part of the challenge for this, and this is said with great respect and admiration for CMS, but I think and because I recognize challenges with data, but part of the reason for this is, I think, data issues. They're 2 different programs. They're kind of siloed. Medicare's over here, Medicaid's over there. Do you know what I mean? And so can you talk a little bit about this? Because I would like to energize the research community somewhat to start thinking about dual eligibles, because I think they're an important and understudied group. And I'm just curious, from where you sit, obviously they're 1 in 5 Medicare recipients. There's no specific question, but just talk a little bit about duals and how the research community can help, and how CMS can help the research community help.
Yeah, no, I think you're right. It is a very important population to focus on, because they tend to be some of our most frail. So very high cost, very complex social needs coupled with complex medical needs, who otherwise can fall through the cracks. And I think that's in part why the Affordable Care Act created the Medicare Medicaid Coordination Office, to try to be able to work on this and better coordinate. I gave that example of where we are trying to make improvements for dually eligible populations by, for example, requiring social needs screening. And we're also looking at where in the alignment of our programs, I mentioned the quality metrics, where we're thinking about equity metrics as quality metrics, and where we can align Medicaid and Medicare, that will really bring a lot of momentum to addressing the root causes of many of the health needs of the dually eligible population. So there definitely is a very coordinated effort to get more of that alignment. I mentioned the Medicare savings programs. That's another area where, we're working very closely with, the Medicaid and CHIP and states, because the Medicare savings programs are run by individual states for people with Medicare. So where can we collaborate to make enrollment easier, right? So that you can get people into these kinds of programs. And I think lastly, the care coordination is also key. Where there are opportunities for us to not only encourage equity through, the social needs, language access, et cetera, but also where can we leverage some of these models like accountable care organizations for the dually eligible population as well? Like, where can we partner across the Medicaid managed care organization and the Medicare side so that you're really coordinating people's care? I think those are all areas that are ripe for research where, seeing what is working, what impact does that have? And then we can see how can you further scale that.
Great. Thank you so much for that. One thing that I think is interesting, you know this, Meena, but many of the people tuned in do not know this, that the annual budget of the agency that you are the administrator for is larger than the annual budget for the US Department of Defense. So I guess one question I want to ask is, if you happen to bump into the Secretary of Defense, would you say to him, just so you know, my budget's bigger than you? No, but it's a really big program. It's an important program. And your presentation really, I found it quite inspirational, sort of thinking about how we can help people to achieve their, I forget what exact phrase you use, but their optimal health. Mm-hmm. Which I did actually, when you kept saying that, I started to feel guilty about the donut that I had right before we started here. But in any case, but the program is, as you know, it's complicated. It's a complicated program. And you talked about Medicare as a lever, but to some extent, Medicare is the sort of combination of a million different levers, services that we're going to cover, amounts that we're going to pay for it, outreach that we're going to do to help providers, to help enrollees, and so forth. And I'm curious, as one thing, so I'm here in Silicon Valley right now. And one thing that is true in Silicon Valley is that many of our largest and most successful technology companies have sort of hired these huge teams of economists to try to optimize everything they do. Because everything's a choice. Like every price is a choice, every service covered is a choice. So I'm curious whether and to what extent there's an interest in an agency like CMS in mimicking some of what, say what you will about tech firms, but part of the reason the US economically has done so much better than other industrialized nations in recent years, maybe not as well on equity, we can talk, but like in terms of just per capita economic growth, has been our technology sector. I'm curious, it's kind of a question, but it's kind of a nudge too, whether CMS wants to try to mimic that by bringing more in-house evidence gathering and creation. Because there's clearly a million questions that you as the administrator of CMS would like to know. You talked about sometimes there's a trade-off. We can do this thing, it's going to cost more money, but what's the benefit? And is the benefit sufficient to justify the cost? So you can imagine a big team of people. I mean, the annual budget of Medicare is much bigger than the annual budget of these tech firms that I'm talking about. Do you see what I mean? So because there's just you could think about optimizing all these little levers more.
Yeah, I mean, and we do have health economists as part of our Medicare team for exactly this reason. And I think bringing it up a level, how I look at innovation technology, again, comes back to what is our true north? What is all of this for, right? It's about advancing equity. It's about, improving quality, having, a more holistic view of someone that you're caring for, and about having a program that's sustainable and affordable. And so thinking about new technologies, new care delivery mechanisms along those various avenues. So for example, when we think about telehealth, the Department of Health and Human Services did a report that found that in 2020, Medicare beneficiaries obviously, used quite a bit of telehealth. Black and rural people with Medicare were less likely to use telehealth than their white and urban counterparts. That is an important piece of data that we need to take into account moving forward as we think about technologies. And do they address disparities? Do they improve access to address inequities, or do they exacerbate them, right? Similarly, when we are looking at these, more holistic care models, it presents a great opportunity for innovation. And I've done roundtables with various entrepreneurs who say, we need more people, more providers, more plans to be thinking about care in a broader way, because that's when, if you have a technology or, an innovation that can keep someone healthy and then prevent them from going to the hospital, there needs to be a framework in which that is encouraged and supported. And so, driving towards more of these alternative payment models can support innovation in that way. And it's not simply, doing a virtual visit in lieu of an in-person visit, and it's still that siloed visit that's addressing one, ICD-10 code with one E&M code, right? It's about thinking about that connectivity of thinking about someone as a whole person, where technology can be used to connect the dots across the myriad of experiences that someone has that impacts their health. And then again, similarly on like the sustainability, to your point, thinking about the return on investment. What is the impact that these innovations can have on care, on outcomes, and on, the finances?
Yeah, you hit on so much there. I mean, one thing I would just flag is that, as you pointed out, technology can do amazing things, but it can also amplify inequality. In fact, I would say, I'm not a labor economist, so I say this with some hesitation, but I think that my read of the literature is that when people ask about what has been the biggest driver of economic inequality in the U.S. over the last 40 years, skill bias technological change is considered to be that. It's a little controversial, but it is. I think this issue of does technology amplify or attenuate inequality is a really important one, and in the economy broadly, but in the healthcare sector specifically, for sure as well. So I think one of the reasons, though, I mean, Medicare has this challenge that it has to set prices for services, right? It has to decide what is an annual physical, what are we going to pay for that kind of thing, and it is. I think part of my question about this, and I did not mean to imply by any means that CMS doesn't have health. I know that there are some terrific people there. I was just saying you should like quintuple their numbers, so that we can have even more evidence creation. And I know, having worked with you and followed, your work, I know that you're someone who embraces evidence when it can help us improve programs. So that is terrific. Let me just go. I have so many questions, but I've got a bunch of good questions from the audience. Let me start with a question about Medicare spending growth that's projected. So at CEPR, I often like to say to people, there's basically nothing that my 118 senior fellows and faculty fellows all agree with perhaps one exception, and that is that big deficits are bad. Okay, so everyone at CEPR worries about the federal deficit. Okay, and obviously we've got an aging population that is going to create challenges for us as a society. We're going to have to make some hard decisions on the tax side or on the revenue side. But one of our attendees sent along some data that Medicare spending growth is projected to average more than 7% per year during the upcoming decade, and that's the fastest growth rate among major payers. And could you talk a little bit about, this is from the member of the audience, about why Medicare costs are rising faster than other major payers? Does it mean that future generations of workers will inevitably face a higher tax rate to pay for more expensive Medicare for more people as a fraction of the population?
I mean, I will say again, I think this is a good area of research to see kind of what, the factors behind, any cost growth is. Ultimately, the work that we're doing, I want to make sure that we are providing better care that spends money in a smarter way and leads to healthier populations and better outcomes. And so where, for example, the accountable care organizations, our Medicare shared savings program saved $1 billion, last year, where by aligning our programs we really drive changes on the ground that will improve outcomes. I think that those are all the key pieces to this, where we can get more data and transparency, right, between the work that we're doing, in the hospital price transparency side, where we're doing work with No Surprises Act, where data can be brought to bear also to help to, see where there's competition, further competition. I think those are all, very important areas to continue working on together.
Great. You made a point earlier that touched on the research areas of a number of our researchers here, which has to do with innovation. And I think you made this point that often innovations, like there may be forces that impede incentives for innovations that keep health quality at the same level but lower costs, as opposed to, raising costs by improving health quality a little bit with a new version of a treatment, let's say. Can you talk a little bit about what your sense is? You've been in the private sector, you've been in government, you have a sense of the academic literature. What's your read on why it is that innovation tends to favor, in this sector, more expensive rather than less expensive?
I think in part we need to think about innovation in that bigger picture of how that innovation drives ultimately the care that's provided, the outcomes, and an overall cost picture. I think that's very important. We have various criteria for our different technology add-on payments, looking at substantial clinical improvement, et cetera. Some of these are prescribed in Medicare law. But I do think overall, it is going to be important to look at innovation again, to think about equity, because we want to address issues of equity and not make them worse. And to think about how the innovation can actually change that trajectory of care so that people are healthier and you can avoid larger costs down the road.
That's great. Thank you so much. I made a point earlier a little bit about data siloing, which I think is sort of a systematic feature of federal, state, and local government in the US. You've got an agency, they've got a program, it doesn't often get connected out of that program. And I just wanted to ask whether it's your sense that there is appetite in the halls of power, maybe things have already happened on this front, for unsiloing data, because I'll just give you an example. As you probably know, about 1 in 3 elderly men in the US are veterans. Okay, veterans get a fair amount of medical care through the Veterans Health Administration. We talked about 1 in 5 Medicare recipients are also getting Medicaid. There are these different programs, and sometimes it's hard for the research community, because our healthcare system is so fragmented, right, to get a full picture. So as you probably know, I think it is the most recent estimate I've seen of this, Medicare covers 55% of healthcare spending for Medicare recipients. In other words, they pay a bunch out of pocket. They've got their Medigap, they've got Medicaid, they've got veterans, they've got employer-based and so forth. So can you talk a little bit about whether you see, because I think for the research community, the data siloing is often a challenge. People will say, well, you're not getting the full picture. You're only looking at Medicare. You're only looking at Medicaid. You're not considering these other things. Do you see room for the research community to try to light a fire under policymakers to unsilo data somewhat?
Absolutely. I think that is an interest of ours. I work closely with Mickey Tripathi, who's the head of the Office of the National Coordinator for Health IT as well, where there are those opportunities to have better health information exchanges and try to get data across different systems. That's what's going to enable ultimately to be able to analyze some of what we've been talking about. I think there are real opportunities, not just within healthcare, but then also thinking about community-based organizations and how are we keeping track of utilization of, say, when there's a referral to a meal support program, and then being able to see what impact does that have ultimately on somebody's health and their healthcare costs. I think these are all areas that are ripe for additional work, and where there are opportunities to break down data silos. That's very important.
Yeah, I mean, that's a great example. There are these interventions outside of the healthcare system that might influence healthcare utilization, and similarly, healthcare utilization might influence people's use of things outside the system. And I'll just mention, this is on a different part of CMS, but I know an area that you're very familiar with, Medicaid. We had a great researcher, postdoctoral researcher here last year, who linked up data with Medicaid, from Medicaid, with criminal justice records, and was finding that when people lost their eligibility for Medicaid, especially men, young adult men, that they were no longer able to get mental health care, and their crime propensities increased. You know what I mean? But you can't get those sorts of insights, are impossible without unsiloing the data. So I just wanted, it is, okay, so I should get back to more questions from our audience. So we have some questions about Medicare Advantage, and there are multiple ones. So I'm going to try to sort of combine them into one. There is this question about Medicare Advantage. So I'm not, there's multiple parts of this, but one of our attendees is saying it's effectively privatizing Medicare and fragmenting care. It requires dozens of independent contracts to be able to reach people. This is a barrier to reaching people who need care. What are you doing to stop this fragmentation? So in other words, I can't quite get right inside the person's, but I think there's a question about Medicare Advantage leading to more fragmentation of care and harder access. What are your thoughts? I guess one thing for starters, we talked about Medicare Advantage enrollment growing from 14% when we worked together of Medicare recipients to almost half now. So it seems like more people are signing up for it. But what's your sense about fragmentation of Medicare Advantage?
Yeah, I think Medicare Advantage is an important part of the Medicare program. It is a choice and an option that people have. And my priority is to make sure that Medicare Advantage, just like the traditional Medicare program, is driving towards those goals that we've been talking about: equity, access, improvements in quality, sustainability of the program. And that's why we, did this request for information, so that we can get information on how it's working, what's going well, where there are opportunities for improvement. There were a lot of questions in there, picking up on a theme we've been talking about. There were a lot of questions around data. What data should we have to better evaluate the Medicare Advantage program as well? Where are there opportunities for further research and analytics?
Okay, great. Thank you for that. We have another question about excess payments. Maybe it's excess premiums. I'm not sure, but you may know. How does CMS determine what the excess payments will be for Medicare B and D, Parts B and D, for higher income patients? So there's like higher premiums, I believe, that are set.
That's done by the actuaries. So we have actuaries who calculate, the premiums each year based on, expected utilization and cost, and they incorporate what it was last year. Was there, leftover? Was it a deficit? So that's all done by our actuaries.
Okay, actuaries, they're an important part of the CMS.
Yes.
The CMS team. But I think, just at a high level for our attendees who aren't familiar with what this means, basically, if let's suppose, I think it's the top 5 or 10% of income individuals pay higher Medicare Part B premiums, for example, than all other Medicare recipients for their enrollment. So now you've now been working at CMS for a while, and I'm curious, are there any questions that or any low-hanging fruit of policy changes where you think it's kind of a quote no-brainer? I mean, nothing's that simple, right? There's always pluses and minuses, but are there, if you had your druthers, are there any policy tweaks or bigger changes that could be made, so that's one question. Where do you think the research community is needed most for helping the Medicare program realize its potential for patients, and for the country?
Well, I think the pandemic created just this treasure trove of innovation and changes in how care has been provided over the past few years that provides an incredible opportunity for research to see what works, what doesn't as we move forward. We talked about telehealth as one example. There's been a lot of innovation in care in the home, right? I mean, all of the work around equity and thinking about healthcare as beyond just the traditional siloed, four walls of a physician's office or a hospital clinic, but thinking about health-related social needs. And again, I think the pandemic brought a lot of this to light. It led to, in terms of, the pandemic response, changing the way care was provided. And that creates a huge opportunity for research to see what are the lessons learned? What are things that should be incorporated moving forward, not just for Medicare policy, but for others as well in the healthcare ecosystem in terms of how they do their work. So I think there's huge opportunities there for research that would be very much needed as we figure out, how do we take what we've learned from the pandemic and emerge stronger and more resilient as a healthcare system.
Well, that's it's incredible. Now, one thing that I forgot to mention at the outset of today's event was that Meena was scheduled to be here in person earlier this year, but so we obviously wish that you were here with us in person, but it's, we're super grateful to you for making time for this. I guess for me, thinking ahead, the research community, so I sincerely appreciate that point about the transformation of healthcare at the time. And it's happened in some areas more than others, right? So for example, one area that you mentioned earlier is mental health. I think mental health care has really changed quite a lot because now many people are able to do things virtually, and that may have improved access to mental health care. So that may be something that's quite important. But Medicare, the Medicare program, as you know, is just going to get more and more important in the years ahead as the population age 65 and up is slated to grow much more rapidly than the rest of the population. So this program will grow, and I think that was part of the reason that it is the fastest growing payer going forward over the next decade, is that just the age 65 and up population is growing quite a bit more rapidly. So, but is there, to some extent, we worked a lot on Medicaid, and I think that Medicaid obviously plays an important role. You mentioned take up. I guess one last question I'd like to have for you is, you mentioned take up earlier, and I guess do you view it as a problem that a very large fraction of Medicare recipients who are eligible to be dual eligibles don't take up Medicaid? Do you know what I mean? Like, based on their income and assets, they appear to be eligible, but the take up rate is estimated to be, it depends a little bit, but it's in the sort of 50 to 60% range. So thoughts on that?
I think that's where partnerships are so important, where we need to make sure we are partnering with people on the ground, with communities. There are many people who are, working directly with communities who are trusted, partners that can reach populations to say, hey, did you know you are eligible for this? Let me help you figure it out, right? Let me help you navigate. And that's why we've invested in navigators, in the state health insurance assistance programs, because we know it's so important to reach people on the ground. And there are trusted community partners that can work very directly with people to make sure that they know what's available to them and that they can, better navigate the system. And where there are opportunities to simplify and streamline enrollment processes, that is also something, that we're looking into. Like the Medicare savings program that I mentioned earlier, we have a proposal to, streamline enrollment in that, for example. And that's something that we're continuously looking for feedback as well of where we can improve for things on the ground in that last mile.
Well, that is so, I so appreciate your all of your insights that you shared with us today. And it's like really a tremendous honor to host you at CEPR. Like I said, I wish it had been in person, and I remember being super impressed with you in the very first meeting that we were in together many years ago. Very eloquent person from HHS. Who is that person making all those great points? So I'm even more impressed today, and I'm grateful to you for your public service. I mean, I think it's important for the country to have great people like you in leadership roles like that, for our not just leadership roles, but in all roles in our public sector, because it's really, you're working on behalf of many of the country's just most vulnerable, and it's a hugely important part of their lives, but also, as we mentioned, of the economy. So it's great. So I will just say, if you choose to wrap up at some point at CMS, if you ever want to just come and think deep thoughts and connect with our researchers and our students, you'll always be welcome to come to CEPR. We'd love to host you here. And with that, I just, keep up the great work you're doing. And just, to the extent that the research community here at Stanford, or more generally, can be helpful to you and your colleagues at CMS. I mean, most of us went into this business because we want to help make the world a little better. And so we're here to help to the extent that we can. So please don't ever hesitate to reach out to us with that.
Yeah, I mean, that's what I was going to say. I mean, a huge thank you to all of you for the work you do, because that research can help guide how we can improve our programs, right? Again, where are things working? Where are there gaps and opportunities? And to be able to iterate together, it's very important. So I appreciate being able to join all of you today.
Okay, well, great. Well, thank you so much, Meena. And I hope that, things go well, that you have a wonderful December, and please always never hesitate to reach out. And for all who have joined us here today, thank you so much. We'll be sending out information soon about more exciting speakers on the horizon from places like the IMF, the White House, and business leaders and more. So please be on the lookout for your email. And with that, happy holidays, everyone, and have a great rest of your week.
Thank you. Take care.
Okay, thanks.